Good morning, everyone.
Morning.
Good morning. So now we got you up and down. Let's get you up again for a pledge of allegiance. This is the September meeting of the Finger Lakes Regional EMS Advisory Committee. I pledge allegiance to the flag
of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, so first Finger Lakes Regional meeting under new governor. Figures just as I'm getting ready to leave the state, he decides to leave. I probably won't stay around anyway, but that's okay. So let's get out to the meeting. Call to order. Approval of the minutes from July 20th of 21. If I can have a motion or any changes, addendums, anything? Motion?
Motion.
Second. Does anyone have anything like to change or add? Discussion? Aye. Anyone opposed? Very good. Standing reports, we'll move right along. Program agency coordinator.
So a couple things going on. I emailed out to all of our agency leader group, the email chain that I have. And basically the state recognizes that the drop times are getting longer and longer and longer. There's now what they call a Drupal form that I emailed out to the leaders. If you didn't get it and you want it, let me know and I will get it to you. They are tracking the drop times for the EMS people going into emergency departments. It's specifically becoming a big issue in both the Buffalo region and the Syracuse region. As many of you know, the Syracuse hospitals have been essentially on a rotational diversion for the better part of 2 weeks, 2.5 weeks. So it's an issue that's only going to continue to get worse, I think. So I mean, just if you're noticing trends, let us know. Let the state know. I'm not sure what can be done, but I mean, as long as we're documenting that there's issues going on, I think that's what we need to do.
John, there's a lot of conflicting information from the last state meeting about what they're actually tracking. They were more focused on like stroke and trauma, when I think they should be thought we were going to be focused on overall drop times. That's what it made it sound like.
There is the Drupal form, I think, was specifically for drop times that came out. I think I said that yesterday. So, I mean, report what you need to. If your crews are having an issue, then let us know so we can keep track of that and get that passed along to the appropriate people. So our annual conference is in full swing with planning. It's going to be a 2-day event, February 25th, 26th of 2022. At this moment, it is an in-person conference. We have still have some lecture openings that we're working to try to get filled up. If you know of anybody that might be interested in performing a lecture or you want to do a lecture, please let me know by email so we can schedule. So the state's been doing a lot of training stuff. They did a leadership academy that they're working on creating a curriculum for. It was more towards the interpersonal leadership stuff to get you looking at, what type of person you are versus, the actual skills necessary to be a good leader. So that curriculum will be coming out shortly, I would imagine, and developed, they're using the program agency folks as essentially the guinea pigs for the programs. So that, the hopes is that we start focusing on provider mental health and preventative stuff rather than, letting it escalate to the point where, we're behind the eight ball and individuals are making attempts on or worse. So that's about it for right now. So I can remember it.
You can step right back in if you need to. You can step back in if you need to.
Sure.
Yeah.
REMAC program came back, last week of August for their last part of their semester. They will be done in May of 22. Applications are out for the next class slated to start in January of 22. If anybody is interested, give a call to the office, we'll mail one out to you, or they're up online. Other classes, we have all the enrollment, done, registrations for the fall classes. There are some smaller classes going. Enrollment is down. Some of them said they're still concerned about what's gonna happen with COVID. They were afraid of another shutdown, so they're kind of holding off to see what spring or January brings. And the other thing is the fact that the SUNY regulations, are that every student that is on a college campus, must be vaccinated by September 27th for COVID, or they're no longer to stay in the class on campus. So we only have one EMT class that's offered on the Geneva campus. The rest of them are all out in either fire departments or ambulance agencies because they do not fall under the purview of the SUNY having to be inoculated. So we moved them out to try to keep as many people as we can. Jamie?
Will that affect testing though, when they have to come in for their skills for the state practical?
Supposedly not, is what I'm hearing right.
Okay.
Because I asked that about the evaluators, I asked about the council members and that because obviously a big group like this, we can't put in our conference room yet because we're still only at 75% capacity. But training it at an executive can come in because there's only 10 of them and we can do the 6-foot rule. But I did ask about the testing and that because I said we have evaluators that are coming in, we will have students from outside. And they were said because it's just a day thing, and then we'll have to do a similar thing to what we did for the last couple of classes, was part will come in the morning, part will come in the afternoon, so they're not all there at the same time to congregate. That's it.
That's it.
Jack, so just to dovetail in, we did offer a number of standalone CME courses. We offered 2 fundamentals of airway, basic airway for the BLSI PEMT folks that ended up being canceled because of no attendance. Nobody signed up, and we just canceled an ITLS class that was scheduled for early November, or I'm sorry, early October, because of nobody signing up.
Were those on site or virtual?
It was on site. We still have a difficult airway class that is, we have maybe 7 or 8 people sign up for that. So at the moment that is still on. If you've got people that want to go to it, that was the time to get that registered because it won't happen again for several more months.
All right, thanks.
One more question for the students. Do we have any working MOLS training?
Not yet, people have not put that up, I've been in contact with them.
Okay.
So what we're doing right now is we're watching.
All right, very good. From my perspective, I do have a list of DOH investigations, reminding folks that it's not so much the importance of what these folks did or what their penalties were, but the fact is that these are people that you probably don't want working in your agencies. If any of these names are familiar, please speak to the health department. Thomas Warrington is of Blue Mountain Lake, New York. He was charged and fined Eric Geisler from Scotia, New York. His suspension was stayed, but he was assessed a penalty of $2,000. Will Davis of Astoria, New York. He was fined. Kevin Steger of Beacon, New York. He surrendered his certification. Joseph Van Simon of Long Island City, New York. Penalty and probation. Francesco Berardi of Staten Island, New York. Penalty and suspension stayed. And James Philbin of Staten Island, New York. Assessed a civil penalty of $10,000. And his certification was revoked. Okay, so hopefully none of those names are familiar. And that meeting is coming up next month. They're still not sure if it's going to be virtual or in person. There's a vote out now. The vote should be out in a couple of days, so they still don't know for sure. I have nothing else to really add to my report today, so we'll move ahead. RSI and RSA committee.
Yes, I guess. So just real quick, so we had a meeting last Monday, and we're trying to change the focus of the RSI program. Initially, the focus was getting new providers in and pumping up the numbers. Now we're going to focus more on maintenance. I think we agree that future classes will be driven by the agency's demand. If, let's say, Finger Lakes has 7 people that need the RSI, especially SCT or others, we're still going to take new agencies on a case-by-case basis. But I think the focus now needs to be on maintenance. And that's another issue, is that our classes need to be more physician-driven. We've been having a hard time, as you know, trying to get physicians to assist. And the education, unfortunately, has kind of, I guess, it decreased in intensity, for the lack of a better word. And that's really probably through no fault of anybody, just, you know, it's a lot for a couple people to set up and a couple people to teach. So future classes, we're really hoping for more physician involvement. New faces would always be great. We're also looking for more agency involvement. What our committee is going to do is we're going to be focusing more on QA in conjunction with the Finger Lakes QA. The committee is going to be looking at charts. We're going to be setting up some trainings, especially with SCT involvement. I know it was a big push to get all SCT providers RSI. I feel that RSI and SCT needs to be as a separate component for SCT, so we're going to be working on that. So basically, for the end of the year, we're just going to be working on maintenance, getting the number of providers, getting charts down. Also encouraging, and I know probably this has already been done, but we're also encouraging RSI agencies to keep track of their IV successes and their intubation successes, and kind of report that, make a standard. We had a standard for the region, I think a couple years ago. We're looking to get back at that. So our next meeting is going to be focusing more on maintenance, looking at these charts, seeing what educational components come out of it, and then working forward. So that's all I have for that.
Did you guys go so far as to discuss your thoughts about, with COVID, in person versus virtual?
We did not, for meetings or for classes, or I know there's some discussion about, there's some people that did not like the format it was, with 2 virtual trainings and then the in person.
Obviously, we're working within.
Yeah, I mean, we're working in our system. I personally thought that was better. At least it ran more smoothly administratively. But it comes down to, it's very hard to coordinate everyone's schedule, to coordinate practice time, and to coordinate everything to come together for a smooth session. I think we do well with what we do now. There's always room for improvement. What I think we don't want is, and I know Dr. Surratt says this all the time, we don't want to go back to where it was. I know medical directors of agencies have a huge say in it, but they should not have 100% say. Do you know what I mean? You know, that was the problem last year. You know, the medical director said, oh, you X, Y, and Z can do it, and they hadn't gone through our class. That's what we ultimately, the goal is to not go back to. But between the medical directors and the physicians in this room, we are looking for that guidance and that education to come through to, you know, keep our providers up to date and the new providers up to standards.
So for those physicians in the room, I don't want to aggravate your PTSD by any means, but when we were all residents, we had to bring cases before other attending physicians and our own colleagues every single time we were on call. And it was a good way to break out into a sweat, have chest pain, difficulty breathing, but also to learn. And I would volunteer as I leave, because I'm going to miss some of this. I would certainly be willing to take on maybe one night or 2 nights a month virtually, leave it open to whoever's interested in signing in and bringing cases forward. I had a case yesterday that confused me, or was a tough intubation. Let's talk about it. Nothing planned. We're just going to plan to meet. We're going to be wide open on Zoom, 7 o'clock on Wednesday night. Whoever wants to sign in, sign in. If you want to bring a case or 2 cases, I'd be happy to talk about it. If any of the doctors should do the same. But maybe start.
And the other thing that we touched on briefly in the past, and I want to bring it back up, is medical control. I know that a lot of the standard right now is our agencies use their medical directors for medical control. I was wondering if a sit down, or maybe just an email discussion with the agency. I have a feeling that's the way it's going to be. Probably is agencies contact their medical director directly for orders instead of trying to call a hospital. I know in the past there's been some lack of communication and some orders that needed to happen did not happen because of lack of knowledge of provider knowledge. You know, the provider on the phone does not know the paramedic talking. I'm wondering if it's useful to have all the agency medical directors of the RSI just kind of get on the same page. You know, this is what we're expecting from our agencies. This is what our agencies are expecting, you know, regionally wide, what we're going to say for orders, stuff like that. I know, like I said, I know that we've talked in length about what's the best way for medical control. We talked about clearinghouses, we talked about this, and it's just, it has to come down to agency medical directors. Not to say I want to take medical control away from hospitals, so that's not what this is about. But when you're calling for orders from our side, it's a life or death, and this is something that needs to happen. And I personally don't want to take a chance of calling a hospital and talking to a provider that has no idea who I am and did not feel confident in doing this procedure because they don't know who I am and getting denied an order.
Well, there's a lot of reasons for that, as you well know. The hospitals are swamped. They don't have time for someone to spend 5-10 minutes on the phone giving them control. So they're going to keep it as short as possible. And, you know, all of us that do med control for these agencies, we know when you guys get on the phone with us, many times, you don't even have to say your first words, just from the way you say, hey, hi Jack, hi who. I can know right away you got a sick patient, you know, and I think there's a lot to be said for that interaction with people that you do know. There's better, I didn't think there was such a bad comment. I didn't mean to upset you.
You know, not speaking for, not knowing what the doctors in the room feel, but I know that especially one major hospital in the region, we tend to get a lot of pushback because we do not get orders from that facility.
I think the best plan we have currently is to keep utilizing the agency medical directors. I would love to see a regional medical control at some point. We've spoken about this for 20 years, and maybe someday it will happen. Right now, I don't see that happening. I think we are stuck with that, but I think keep bringing it up, keep discussing it. I think someday we'll have something better available. We just don't have that now. But I think trying to keep the current medical directors, and there's only a handful really, all giving the same medical control. You know, we don't want one medical control physician doing something way off in left field We want everyone doing the same. So I think that's a great idea. And you know, whether it's done Zoom, in person, email, wherever you want to do it, I think it's a good idea.
The last thing that I have that I forgot to mention is the committee is talking about creating a form. For those who are old enough to remember, there used to be, LREMs used to have an intubation form. We're actually considering creating our own. I have an agency specific one that I use. What we're trying to talk about possibly creating a regional form, not just for the intubation, but like it's like an RSI form, like it'll say the medical control orders and stuff like that. We're throwing that around. I think that's probably going to happen in 2022.
Different from what's in the SCT protocols?
Similar form, but more
Similar to
RSI.
like the Central New York
Yeah.
intubation.
That's something that you think should be incorporated into the SCT protocols?
Yeah.
So it would be pretty easy to come up with that new form and have it into the SCT protocols as part of that.
Yeah, I think it's important, you know, checks and balances, you know, just so that there's no question, you know, come down the line. So you have a physician sign this form, and then you fill it out, and then you subtract it to your chart and send it to us. So that's all I have. So thank you.
Thank you.
What's the purpose of the form,
The purpose of the form would be checks and balances.
as far as?
So the old form, I don't, you know the Central New York form, right?
Yeah.
Okay. So this way, you know, it shows the order, and then it has a physician to verify that this is the order and this was good.
Yeah, it also will serve another purpose, because it can be used for a quality improvement study on my end of it too.
I was just wondering, to me, those calls should be reviewed anyways.
Oh, they are.
Yeah.
This is just an extra check and balance.
The problem that I'm having with these calls is they're not showing up as RSIs. They're showing up as advanced procedures. It's coming in, depending on how the chart is completed. When we first started, I would get these RSIs. I'd have the chart that night or the next morning, and I could review them. But now, they're not popping up because they're not being called an RSI.
And that's the other purpose for this form, is now we have RSI agencies on multiple charting platforms. And so our one report is not going to catch all the agencies.
No, I think that's very important because we are missing a lot of those. And number one, is RSI techs. They got to show that they've done something, and they may not be able to prove those numbers. And number two, we want to know what they're doing and how they're doing it. So that's an important concept to have. So thanks, Michael. Anything for advanced practice?
No, just you're gonna talk about Q&A.
Yeah, so Scott and I, Dr. Glick and I had a preliminary discussion, and we're going to try to redirect the Quality Assurance Committee and get them more active and take more of a lead role in the review process. So that
Maybe not necessarily complaints, but
Just
charts at random.
overall randomized review, not stuff that just comes to the thing, because we all know that some so
Be careful.
So we just want to, try to engage them a little bit more.
Perfect.
Last time around, there is, so I was able to, I got 12 or 15 BLS providers interested in participating in this group. We had a preliminary meeting already, and I provided them with my thoughts on the process and where I would like to envision this going. Gave them some examples of programs that are in other regions around the state, and told them to go back and review those programs, the paperwork, and come back to the next meeting, and we'll discuss them further and divide out the work, maybe have, you know, because there's, like I said, 12 or 15 of them, maybe have, you know, 3 or 4 on each group that we're trying to tackle, and they, you know, split the workload up a little bit amongst them. So our next meeting for that is scheduled for October 14th at our office.
Very good. This is something we should have done a very long time ago. How many ALS providers in the room? How many did not start off as EMTs? You didn't start off as an EMT? We'll talk later.
I was that radio guy.
Almost everyone started off as an EMT. We've got to get more EMTs basically involved. I mean, whether they're volunteer, whether they're paid, however we do it, this is super important. And I can see this committee, depending on how active they want to get, doing a lot of good. Going to the schools, trying to get stuff out to the community. They really should be approaching the politicians locally,
So-
looking for things.
So the best part of this committee is there's a representation. There's a couple of career folks on there. There's several people from small BLS agencies. There's some BLSFR units. So there's quite a diverse experience bank of individuals on this committee. So I think the work that they do, and they all seem to be very enthusiastic about the project.
I would invite a couple of local politicians to your next meeting. You can
Wow.
send the invitation, they don't necessarily need to
Oh,
come to it.
Have them, started the process before you
Well,
introduce.
get them involved as soon as possible. There's no reason why they can't be pushing stuff to help generate some basic providers. Because if we don't generate basic providers, we're all gonna go out of business. So, I hope this committee does well. Do we have anyone here from the Bureau?
No, Mr. Majors sends his apologies for not being here. He's in the middle of a narcotics investigation within the region.
Within the region.
Well, the western region for him is anywhere
Okay.
between here and Buffalo. So they send their best wishes to you, and
Ed's gotta be thrilled.
they apologize that they are not here.
He's celebrating. No more multiple calls at all hours of the day or night. All right, Mercy Flight Central.
Yeah, a couple of educational events. Tomorrow actually is our next virtual event. That's up here. That is about 300 registered for that, 6 p.m. It's all online, 3 hours of free CME. So if anyone's still interested, we can still, nice about virtuals, we can accommodate basically as many people as sign up. On the 1st, this is more for the folks whose areas are to the east or stretch to the east. The 1st of October, we have an in-person CME event out at Vernon Downs. Again, it's a day long, the fair, meals provided, the usual thing. Still in person, right? As of now, still in person. So that's good to be back to do some hopefully in-person education as well. So all the information's on our website, social media, feeds, and all of that. So that's all I got.
All right, thanks. LifeNet Guthrie? No representation today. Any of these specific ground EMS agencies? I'd like to comment about? Sir?
I didn't know if we should do some of the business. I had a meeting with some of the REMAC docs about general concerns of EMS and I'd like to get a committee formed to start looking at this. I think we're working against each other in a lot of ways. I think it all boils down to money in general.
Yeah.
I'm very concerned. We've seen a significant rise in the mutual aid we're doing. I was wondering if we could get some data on that. I contacted Deb.
They're still working on it.
It's hard to track. I guess I'm looking at a lot of common issues. It's included. we don't get some stuff together to figure out what our system is gonna be, how we're gonna measure it, and what our performance is, because I haven't seen really anything out there on a regional wide issue. My concerns, and I think everybody's feeling it, we know we got staffing shortages, we know there's gonna be more coming. I lost 4 providers last month, totally out of EMS. FedEx, UPS is starting now at $19 an hour. You know, we aren't even close with new EMTs. So when you were talking about EMT recruitment, I think that's gonna be a tough nut to crack. I think you're gonna see a big move. These hospitals that are overwhelmed are already reaching out to see how they can put paramedics in the hospitals. See if they can self-educate through an education thing, to get them certified within the hospitals, to basically use the skills we currently have. And I think paramedic techs at a couple of the local hospitals in Syracuse pay significantly more.
I believe that's not allowed in New York State.
I believe there's a big push going on. I know there's a big push going on.
They're gonna be fighting the Emergency Nurses Association on that one.
Yeah, well, they can't provide, and their providers are getting burned out, and there's a lot of issues. You know, they can do EKGs, they can start IVs, they can do blood draws.
I agree.
So,
Now, do you think this, so I think this all needs to be discussed. Do you think this would all fit into one committee, or do you think it's more than one committee?
I think it needs to start with one committee to figure out. I don't know. John Smith, doesn't matter to me what it's called. I
think you need to have that committee, you need to select people involved in it. I think the data is gonna be easier to find if you can be specific in what you want. You can come up with a list of exactly what the data is that you want. It'd be easier for these folks who have access to the data to get it for you. But
I think a lot of it is people are tracking data differently, and they aren't merging. I contacted Wayne County, how many mutual aid funds? Well, that really depends, you know. I'm like, depends on what? Well, you know, we really can't separate, oh, I'm going to work with a driver only to meet up with Wayne County ALS. That mutual aid or isn't it mutual aid? You know, I think we need to start defining what the system needs to be. I think that, you know, I'm trying to figure out how many mutual aid we're doing to our neighbors and why they aren't in service. I don't even know if they are in service during the day. So now somebody's coming into ours. We are shifting stuff, which I think is great, but I think it could be managed a lot better.
So, do I hear you volunteering to chair this committee?
I'd love to.
Do I hear this committee being called something as staffing committee?
I would honestly call it the EMS review committee.
EMS review committee. All right.
We have a lot of educating to do to our politicians.
So is that a motion?
I can't make it.
I would call it the operations committee, something, because you're asking for coordination, or coordination committee, I mean.
Well, of course, operations fits into the way we have our structure in EMS, so operations. Perfect. I do need a physician that would be willing to make a motion. Motion. And a second.
I'll second.
And is there any further discussion? Matt, you made the motion. Are you okay with Al chairing that and him, in whatever fashion necessary, as long as it's safe, to come up with a group to sit on that committee to report back to the REMAC? Yeah, some people could maybe even virtually attend. All right. Do I see anyone opposed to this? Operations Committee, Finger Lakes REMAC, intact. Okay. Very good. Any other ground EMS agencies or anyone that has anything else to add?
Have you heard anything on the EMS mandate for vaccines?
Currently, it is not being covered for EMS. That's the latest we've heard.
So the latest update in my 6 o'clock meeting was from State AG's office. I don't know if you're aware that you could put a hold on that because they didn't have the religious exemption. Which has sparked more conversations as far as medical exemptions based on physicians. So my understanding is that we have 18 providers I'm gonna lose on the 27th. This changes by then. I've talked to a couple other directors and I know we're losing staff. I wanna know what this is gonna do to our system.
We just had a memo come out yesterday, Al from HR, that explained, I think, the stay that was placed on, so the stay that was placed by the New York courts was that you could not exclude religious exemptions. Conveniently, that hearing, of course, New York State opposes that, but that hearing does not happen until the 28th. So a day after the mandate.
And you guys are only mandated if you do it in a facility, right? Because the last state leaders meeting, they said 911 emergency agencies did not have to have the vaccine, but those only in a facility.
Just be careful because you have that at the state level, but you have federal level that's now also saying that any federal funding, Medicare, Medicaid,
That's what I was
any kind of
asking.
federal grant monies also are going to be caveated into the vaccine mandate.
Okay.
So I'm sure that there's gonna be a lot more coming on that, but we have that piece of the pie also. So it's not just state level, it's federal level that's impacting everything.
So the discussions with our attorneys about that we threw into and contacted CMS that is fine. We aren't gonna do any more Medicaid transfers.
But you're not getting that money direct. That money's going to the patient. So you are not getting monies directly from the federal government. So I still don't believe that covers you.
No, I totally agree. And it's, until we figure this out, I sent an email to Ryan and said, Ryan,
I also emailed him and he said, as soon as I know more, I'll email you.
but
Now, if you got a grant, have you got any grants?
Not this past year, but we have got.
But you have previously. You are covered under that. They don't, because they are for profit, they don't get any grants. Yeah. And the monies they're getting from the federal government are indirectly to them, not direct.
So what Finger Lakes is doing is we're reaching out to all our providers. We gotta have it in by, I think it's the 27th. If they want a religious exemption, we will honor that. As far as filling out the forms, they're like, well, I'm like, I don't know who you want us to report that to, but we'll keep records of it. And if this way, if something happens, we'll address it on a case by case.
Yeah, and religious exemption is very easy. It's a one-line, my religion prohibits me from putting messenger heart name to my body. That's what's being accepted.
Yeah, so that's.
I think when we look at it realistically and reality-wise, we've been going along at the same pace now for a year and a half. We've had very few of our crew members at Finger Lakes or throughout the agency, well, with the exception of the agency, get sick. So we somehow have been managing. I'm not saying, and I by no means say that I agree or disagree with vaccination. I'm not going to go into that, but somehow we have managed. So I think realistically, if that's the way it has to be, if we can keep people, right now our goal is to keep people on the streets responding to 911 transports. Somehow we have to keep those numbers up. So whatever it takes for us to do that, I think we have to do it.
So my understanding is the REMSCO has the legal authority to coordinate EMS resources. And for public health, I think that's a coordinate EMS resources within it.
And what does that mean?
I think it's a very broad step, but I think at some point that's gonna have to be defined, if it's not defined through the state. I think that there's nothing preventing the REMSCO from defining it itself and reaching out to local government for local laws or policies on it.
It sounds like something that should fall in the operations committee to discuss and bring forward.
I'm good with that. I just see one problem initiating the other, Stupid decisions because they're tired and they aren't thinking. So, I think we need to move fairly quick on this.
Well, Air Medicine has been through this before, and they've set up some pretty good policies on crew rest. If you've got crew members doing 24-hour shifts and they're not getting any crew breaks, that's not healthy. Air Medicine knows that very well. Where ground needs to incorporate something similar, and if there's no crew to do the call, then it does need to go to mutual aid, regardless of how far down the channels that has to go. We may need to be looking at things like that. You got limited crews on the road, they're running around the clock. I'd rather see a patient wait a few more minutes than have a crew respond and make a big mistake. So, again, something else for operations committee discussion moving forward.
Okay.
But,
Is there anything you guys want me to focus on?
I think the committee can figure that out once we get it going.
but seriously, your focus is gonna probably have to be towards staffing and trying to cover the calls that we've got. Obviously, that's a big fight right there, but. Thank you. All right, moving on, Thompson Health System.
Just, again, this is a little bit beyond the purview of my report, but one thing about the New York State mandate, I believe last night was already been extended 2 weeks to October 12th. And then my understanding is that they will respond exclusively to briefs, not in-person arguments. So that's also a good sign. So at least from, again, I'm not touching on the federal mandates or related to federal funding. Probably for New York State, per typical, it's going to be in the courts extended a while. So modus operandi will probably be staff where you are right now for religious exemptions. So kind of good news. Again, I'm not a legal expert. Related to Thompson, and we're in unprecedented times, I know, in the whole nation, but capacity is our major issue, and not really even our ED volume, which I'm sure similar to everyone else is significantly increased to pre-pandemic levels and beyond, is our inpatient census. And that is largely related to our ability to discharge stable patients to long-term care facilities. So what you're seeing at your prolonged drop-off times is all related to what's going on in the upstairs floors and the inability to get those patients out. So that's all I have.
Thank you. Clifton Springs.
So I got a notice from Clifton Springs a few days ago saying that they are no longer doing inpatient dialysis. Inpatient dialysis, their dialysis services are suspended due to
Medical services in certain counties.
You don't do inpatient dialysis in North Point? Thompson?
We do.
And
So we don't-
limited in Geneva. Wow.
Is Geneva?
Yes.
Okay.
So we got that notice the other day, where would, so dialysis patients within the Newark and Clifton system that require an inpatient stay, would they, how would that work then? Even from a system standpoint, would they be directed to Rochester Regional, or would they be directed to either Thompson or Geneva?
Currently, it used to be kind of a cause of confusion in the past of which hospital, the two of our hospitals they go to. Right now, what we do is we try to accept them if they don't require dialysis in the next 24 hours to 36, depending, and we would try to transfer them to, RGH or our nearest dialysis hospital that we could if they just for dialysis and bring them back. Right now, it's just like checkers, whether there's even somewhere to send them. So, again, we're doing our best. And it's, if EMS is aware that this is an issue depending on, I think it's the acute patient that's short of breath that may need emergent dialysis is what we best they can, but
And then
we're gonna take all patients regardless.
Exactly.
And
Right, stable.
to know that we will stabilize them the best we can and do whatever we can to get them to where they need to be for dialysis.
Transfer patients from the newer ED to Clifton
Yes,
inpatient.
Can we get a memo out to everyone itemizing who does or does not do hemodialysis?
And our understanding from the memo is on a temporary basis.
Definitely.
Yeah.
And until the service can, because they had a contracted service that would come in, and it was only active certain days of the week. It was not a full dialysis program.
That causes a huge issue with us, you know, and with the mutual aid calls going up that we're doing, transfers, regular calls. We're in the midst of trying to figure out how we're gonna prioritize these. A lot of the hospitals, the home stuff is probably gonna be put on hold. That would be the first thing we look at. We just don't have the time to wait. Returns are killing us. You know, you get there, the doctor's office isn't ready, you know, you're waiting, is it worth going back in service, isn't it going back in service, they close at 5, you know, these are big problems that are taxing us.
I had talked to you about that after the meeting. I got some ideas to talk to you about, okay? Remind me. But yeah, there's no question, it's, you know, to send someone to the city for dialysis and bring them back, you're now tying up at least one crew or two crews. Yeah, this is really terrible on the resources that are limited already. But we're gonna have to think outside the box. Geneva General Soldiers and Sailors.
You can just replay Dr. Osborne's speech. It's the same issues, it's the exact same issues. We can't get patients to long-term care. So that's, our patient units are full, which causes boarding in the ED. I will share an anecdote. Yesterday, we have a patient needing ICU care at Soldiers, and Matt and I think have both made a hit list of hospitals in Buffalo, Syracuse, Rochester, and South, and 11 hospitals in those regions have not one ICU bed as of yesterday. There's no capacity.
And this is throughout the country. If you look at any of the emergency medicine, social media stuff, some of these guys are calling 3, 4, 5 states
7, 8, 9 states over
to try and get.
is where they are down south. So if we're heading towards that in the next couple of weeks, we're hopeful that the COVID bump, it seems to be going down south, and
Yes.
generally 5 to 6 weeks of increasing numbers for this Delta variant, and then it starts trending down, and that's what we're now starting to see here. So at least for, you know, the COVID being a part of this, it's certainly nowhere the only reason we're in this situation. It seems to be trending down, so we're hopeful for that.
I certainly hope so, because I moonlight down south, and when I was down there a couple weeks ago, I gotta tell you something, working in the Finger Lakes was nothing compared to what I walked into down there. And going back down there in a couple weeks, so I hope the trend is, and I hope you guys don't see what we were seeing down there, so.
So, and also, you know, just to compound their situation, long-term care is no longer accepting patients in many institutions. So many of your nursing home facilities are just not, because they're
Closing units.
Yeah.
The
They're
board
not
just put out a
accepting.
statement yesterday that they're not accepting anybody.
Right. So,
Well, again, the hospitals are gonna have to start thinking outside the box. There's a lot of empty beds that could be filled with these long-term patients. They may have to hire sitters, tenders, whatever you wanna call them. All the nurses that have quit for various reasons may have to come back to work and do bedside nursing. EMTs, CFRs, whatever, may need to come and sit by patients, feed them. We've gotta utilize the beds that we've got empty and open up the beds that we need for sicker people. There's gotta be something we're gonna have to do, so, but I'm not a hospital administrator. Newark Wayne.
Ditto.
Ditto.
We're always trying to maintain an open stretcher, so we never wanna see EMS sitting there waiting to put a patient in bed, so we're always keeping an EMS stretcher open, maybe in the hallway, maybe in the lobby. Obviously, we'll always, accommodate sick patients, but we're doing our best to kind of prevent that, but yes, again, same thing, we're boarding in patients for days at times, and, long-term care patients upstairs, and COVID positives upstairs, that we just can't go home.
All right. Do we have any else business to further discuss? None. Any new business? Clinical requirements for classes.
No, just tentatively right now, all the hospitals are still available for the paramedics and the AEMT kids to be able to go in and do their clinical, follow the doc, follow the nurse, or, intubation, different things like that. We're still working with the hospitals, and they are very graciously working with our students. There may come a point when this comes about where the hospitals may have to say, no, we can't take students because we're way too full. And we've been working with the state, this education department there, because we had a sponsorship meeting the other day, and a lot of the other regions are asking what's the alternative if we can't get the kids into the hospitals. And so when the executive order was here, we could do what we called scenarios for the students. We had actual patient scenarios that were written up and approved by the state that we were running with the students. And normally, like the basic EMTs would do 12 patient contacts on an ambulance. The state was saying 2 to 1 for the calls because each scenario should take approximately 20 minutes to a half an hour. So with that in tow, we had the scenarios to do it. The problem with that is if you have a class of 10, and that's a relatively small class, that means that if they have no ride time done, that's 200 scenarios we have to sit there with those students and do. And that is over and beyond what they are doing in that didactic in the lab sessions, so that is an increased expense to the sponsorships, obviously, trying to come up with getting all these students scheduled. And they listen to that at the state because they're like, well, we have to come up with an alternative. It's like, okay, fine. But, so that's where we're setting right now is, as long as the hospitals are still open and still taking the students, we are pushing them towards that. You and I had to do some rearranging for the AEMT last year because they couldn't get in. So that's where we're setting with that, is the state trying to come up with an alternative. If any of you have an alternative, I would be glad to listen to that, because I am telling you, doing 200 scenarios gets daunting. So, but that was basically really all I'm looking for, is anybody has any alternatives. I mean, it isn't even, they commented about, well, maybe you could go into nursing homes, or maybe you could go into doctor's office and do patient contacts. It's like, if you can't get in the hospital, they don't want you in the doctor's office, I wouldn't think.
Or a nursing home.
Or the nursing home.
Donna, if we go to the needing scenarios, do they have to necessarily be done here, or is there a way for agencies that have the proper equipment to be able to run the scenarios to help cut
No,
down?
they're actual scenarios that the state has approved for the sponsorships to put in their class.
I see.
Right, but there are agencies that have CLIs and CICs.
Not that are part of that class.
The instructor has to sign off on every one of those.
Okay.
The question needs to go back to the state.
At the moment.
All right, any other new business? Anything else to be mentioned before this?
Yeah. Jack, we just, the region, us as a REMSCO, just want to thank you for the 25 years of service to our region. So we got you this little plaque.
Little plaque?
Right. We wanted
He
to
hit
have
the garage.
just a token of our appreciation.
I promised you a couple weeks ago you were gonna be done with me. I lied. I apologize. I think this time you're done with me, at least here on the REMAC meetings. But hopefully, maybe some virtual stuff, and always keep in touch. You guys have been great.
And you're always welcome.
We're all gonna get your address, right?
Yes.
I already have plane tickets.
Oh, thank you guys. It's really been a long ride, and it's been a lot of fun. You guys are family, so thank you. Motion to adjourn. Now? We okay? Yep. Motion? Second? Adjourn. Everyone be safe.
There's a few goodies in the back.